It is 2:06. I'm here with Chris Burdick. Chris Burdick, of course, is filling in for J.R. Flores, who's taking a few days off. Thank you, Mr. Burdick. Always great to have you here.
Thank you, sir.
And as we do it here, we always keep it fast, informative, honest, and civil. Let's go to our next guest. Every 2 o'clock on Fridays, I have Dr. Bridge Bombi here of Centric Health and Central Cardiology. Dr. Bombi, right now, the topic A for us, of course, has been the coronavirus. And Dr. Bombi comes on every week to lend some expertise for you, the listener. Dr. Bridge Bombi, welcome back to the show, friend.
Thank you, Richard. How are you?
I'm doing a terrific. Dr. Bombi, it's amazing how time seems to move things along, but just in the last week, it seems like we've had some good news. Maybe looks like Johnson & Johnson has a vaccine that's queuing up, maybe for approval as soon as next week. Dr. Bombi, I was saying earlier on the show that just in the last couple of days, I'm starting to talk to a lot of people who are getting their second shot. Some of these, of course, are healthcare workers who a month ago who were inoculated. Maybe I'm wrong. It just seems to me that we're, making some progress here. A lot more people are getting their first shots and people are getting their second shots. And we got the Johnson & Johnson thing out there. And, of course, we do have the Super Bowl weekend. Can you tell us a little bit about this Johnson & Johnson vaccine and how it's different and how that might help us here?
Richard, your assessment is spot on. I think between the number of infections we have incurred, both in the Kern County and across the nation, we have 100,000 or so infections in Kern County. And if you use a simple multiple of 2, there are likely at least 200,000, if not more, people who were infected. So they become part of the solution now because they create an immunity barrier against the virus to jump. And you throw in another, I don't know the numbers of vaccinated in Kern so far, but probably about 50, 60,000. Okay. So that creates, out of the 600,000 that need to be vaccinated, you're talking 35% or so people, I would say the same math applies to the nation, who have immunity to the COVID virus. So what that does is it lessens the chances of it bouncing from one person to another, and decreases the chances of explosion of cases. But even though we have this enlarging repertoire of the vaccines, we need to be cautious. Every time we have had a holiday weekend, I don't care if it was Memorial Day or July 4th, Labor Day, Thanksgiving, Christmas, we have had a resurgence of infections. And it'll be, as you said, it'll be foolish to tempt the fate one more time and have another resurgence. Even though we're making the turn in Kern County number of cases, our ICU capacity is still stretched. We're still denying elective care. I wouldn't call it elective, non-emergent care, cardiac patients to other people who need it. So we need to be cognizant of persistent high positivity rate in Kern County and do our civic duty by not getting infected and spreading the infection.
Yeah. When you talk about, I know we're well short of herd immunity, but we follow up on your thread. You're talking about as more and more people get either the vaccine or build up antibodies from having had it. Did you say 35%? Is that accurate?
35% of the people who would qualify for the vaccine.
Okay.
Because if you take out age 16 and under out, that's about 18-20% of the population. So if you get to the math, for us in Kern County, there are about 650,000 people who would need vaccination. Either they got the infection or the vaccine. So if you have 100,000 documented infection, for every documented infection, there is going to be 1 or 2 persons who had asymptomatic infection, so they don't know it, but they're part of creating the herd immunity. And the same math actually extends to the country as a whole.
So if we I mean, are you warning against falling into kind of a false sense of security as more and more people get vaccinated? People feel maybe like they can come out of their shell a little bit or not wear the mask or do something. I mean, are we in danger as we get closer and closer to the goal of becoming lapse and then allowing the vaccine to get a new hold?
Exactly right. With all those variants coming from different parts of the world, and the one here right here in California called the Californian variant, we can't let loose our guard because those variants have different perspectives. There's higher contagiousness, there's higher virulence, there's a vaccine escape, there is a chance the people who were previously infected will get reinfected. And every time we allow virus to infect somebody and replicate, we allow virus to chance to mutate again. So it's our collective responsibility to minimize the possibility of infection. You minimize it by getting vaccinated and by not getting exposed.
Oh, interesting. We're talking to Dr. Bridge Bombi of Centric Cardiology and Centric Health. Doctor, when you mentioned the California variant. Can you tell me what that is, and can you speak to different emerging variants as a whole?
The California variant, I don't know much about yet, but it has the same alleged propensity towards increased contagiousness. So the British variant, which was the first one in the news, had higher contagiousness. So, Richard, let's say if you have the same dose of the virus and the virus is more adept at gaining traction into the cells in the body, just by the same dose, it's going to infect more cells, and the contagiousness is going to lead to adverse consequences because it's getting a better hold of the host. The second component is the virulence. If it's more spreadable and also more dangerous or more potent, that's a 1-2 punch. The same 1-2 punch has been observed in South African variant and in the Brazilian variant. The Brazilian variant, however, comes with the added danger that the people who were previously infected can get reinfected. With one caveat that we don't know if the data coming from Brazil is totally credible, that the seropositivity they demonstrated that would confirm the previous infection is actually reliable or not. But be as it may, the triple threat we face with variants is increased contagiousness, increased virulence, and the fact that the previous immunity may be overrun by new variant.
God, that's terrifying. Dr. Bombi, you're describing these vaccines. I want you to help me here. Do all viruses, this is going to sound, I know viruses mutate, but do they all mutate and change in a way in response to vaccines? Because I'm trying to pick up on what you're saying. So one vaccine does X, so the virus will mutate in a way that will keep or maybe even improve its virulence or its ability to spread. In other words, when you're dealing with viruses, is it always a moving target that you're always having to look at new vaccines or booster vaccines? How does that work?
The COVID-19 is an RNA virus. The RNA viruses, like the Hep C, the influenza virus, the HIV virus, they have less fidelity in replication. That means that they're internally flawed by lack of a comprehensive proofreading system, that they don't self-replicate as they should. The genome of COVID-19 is more sturdier than influenza, so it's less likely to have mutations. But the flaw in messenger RNA or in the RNA viruses is the lack of comprehensive proofreading. That predisposes them to have errors in replication, and those errors, just from a statistical standpoint, sometimes are evolutionary positive for the virus, sometimes they're evolutionary negative. Negative meaning that they may make the virus less contagious. Positive meaning they make the virus more contagious. The whole notion here is not to give virus the possibility to continue to replicate and explore those options. Yes, when you have a vaccine, the virus has an evolutionary pressure to escape. That's why we developed the antibiotic resistance, because the bugs know how to work around an antibiotic. So the bugs will find a way to work around the vaccine. So it will be vaccine escape. That's what we're seeing in South Africa in both the J&J vaccine and in the Novavax vaccine and AstraZeneca vaccine, that the efficiency drops from 75% to about 50%. Even though the efficiency in infection prevention drops, the silver lining is the efficiency in hospitalization and death prevention is almost 100%. Even when they're attenuated in the response to contain the virus, they're still achieving the hard endpoint, which is lower the severity of the disease, prevent hospitalization, and prevent death.
Okay. Can you talk a little bit about the Johnson & Johnson vaccine, how that's different? Now, this one you don't need 2 shots with. It's just 1 shot, correct?
That's correct. So Johnson & Johnson is based on our pre-existing technology in which they use attenuated adenovirus, which is like a letter carrier. It's a postman. It delivers the letter. All it does is it has a key to the post office box. So it delivers the virus inside the spike protein inside the cell, and then the virus dies. So it doesn't replicate itself. It's just a delivery tool. And the messenger RNA based viruses, on the other hand, are RNA itself, so that makes them very fragile. So this, basically you have a stowaway spike protein interlaced in an attenuated adenovirus that knocks at the door of the cell. The virus is the spike protein is delivered, and it starts the immune response. What it brings to the table is it's a lack of necessity that biologic demands for preservation at extremely low temperatures. So it makes the logistics very simple. So this is like a regular flu vaccine. Instead of storing at minus 94, you just have the regular fridge, not even the freezer. So the transportability, the fact that all the doctor's offices can handle it, even the one with the least acute, makes it very user-friendly option. And we also know when we compare the 95% efficacy of Moderna and Pfizer vaccine with J&J that has 77% efficacy, it's apples to oranges, because J&J vaccine was tried at a time when the mutants were out there. So it was organically reducing the efficacy because of the mutants. There is a fair amount of belief in the scientific community that if Moderna and Pfizer vaccines were tried under the same circumstances, they would have lost some of their proclaimed efficacy also. So J&J is an excellent vaccine, easily storable, 1 shot, prevents death, prevents hospitalization. It's an important advance in protecting the society.
So you would have no hesitation to take the J&J vaccine as opposed to the Moderna or Pfizer?
Absolutely not.
Okay.
Absolutely not.
Okay. What about, there's been a lot of talk about we may be eventually, and you and I have talked about this before too, about are we, once we hopefully get to herd immunity and most Americans have received both shots or 1 shot with the J&J, are we headed to a point where we just assume that every year we're going to get some kind of booster shot to bolster our immunity?
That would be not an undesirable goal. What what's getting our attention now is because the mutations are occurring that are potentially ominous, both from the contagiousness and the virulence standpoint. We have to make sure we deny the virus the opportunity to replicate. Just because we in USA or in the West can vaccinate a lot of our people doesn't mean that the virus goes away. We have to make sure the whole world, it isn't a U.S. problem, it isn't a Canada problem, it's a world problem. If it exists in South Africa or sub-Saharan countries, it will mutate there. And the new mutant will come out as a new virus or a new variant that will override our previous immunity. So it's necessary not to be short-sighted in our vision and to think only of us and allow the virus to continue to replicate, mutate, and have a whack-a-mole strategy with getting infected all over again.
God, that's terrifying. So if there's any region of the world that is not vaccinated, as you said, you could have a mutated virus, so we're going to start from square one all over again. Well, that brings us to, we were talking about the final question here, the logistics of the vaccination, and you had said last week that why are we setting up these mega centers like the Kern County Fairgrounds or Dodger Stadium? Why didn't we just let the medical professionals do it? Which I had wondered in the beginning, why aren't I going to my primary physician's office for this? Why am I looking somewhere else? Has there been any talk since then about, in an effort to boost the distribution, to go back to what you had suggested, just let you guys do what you know how to do?
Richard, I'm a country doc. Nobody listens to me. I don't have an audience in Sacramento or in Washington, D.C.
Okay.
So I appreciate the compliment, but I'm not worthy. But to answer your question, Centric Health has multiple, I think 3 or 4 sites now that have been approved, but they're sitting on no vaccine. Heart Hospital has done a phenomenal job. I think it's a lead center in the community, if not the lead center in vaccinating people. So the bottleneck is the availability of vaccine. So I have no idea. It defeats at least my mind. Why would you create temporary centers, waste a lot of resources when a robust infrastructure exists that can easily vaccinate people? And it's so much easier on the patients because the underlying trust, there isn't any exchange of new information. We're not opening them to a new center where they're sharing the telephone number, the date of birth, their other data. And, the breach of data can happen at every level. But why are we giving more opportunities? So the fact that it's really, truly, to me, it's a travesty of common sense. There is no rationale going that route. Even today, they approved 1,000 military personnel to set up mass vaccination centers, and it just defies my sense of comprehension.
That's amazing. All right, Dr. Bridge Bomby, everybody, we are out of town. Dr. Bomby, thank you so much. Stay safe this weekend. I don't want to hear reports at you and your family at a big Super Bowl party with 100 other people.
It's going to be a large Zoom party, so there will be...
Zoom party. Good. Very good. Dr. Bridge Bomby, everybody. Thank you, sir. Have a good weekend.
Thank you, bud. Bye-bye.
Okay, bye.